Welcome guys to my channel. Today's lecture is about ectopic pregnancy. So, when it comes to ectopic pregnancy, we know that pregnancy normally should be in the uterus, or intrauterine pregnancy is a normal form of pregnancy. We have abnormal forms of pregnancy, which may be due to locational abnormalities such as ectopic pregnancy, where the eggplants where the implantation occurs outside of the uterus, or there may be, for example, hydatid form mole. Now today we'll explain about ectopic pregnancy. As we know, just remember that note every time. The most important hormone detection for pregnancy is beta HCG, or beta hemochronic gonadotropin. So, if your beta HCG is 2000, you should be able to see a fetal tissue or a fetal structure or a gestational sac inside the uterus of the mother through vaginal ultrasound. So if you did a vaginal ultrasound and the beta HCG is 2000 and there is no fetal structures, you should be worried about ectopic pregnancy. But if your beta HCG is 6000, you should be able to see a fetal structures on abdominal ultrasound. So if your beta HCG is 2000 and you can't see fetal structure inside the uterus through transvaginal ultrasound, this is considered, or you should suspect, ectopic pregnancy. If you didn't see any fetal structure inside the uterus and your beta HCG is 6000 through abdominal ultrasound, you should suspect ectopic pregnancy again. Okay? So, now let's explain what is ectopic pregnancy. Ectopic pregnancy is extrauterine pregnancy, which is abnormal. Simply means implantation occurs outside of the uterus. Okay, why? Due to some risk factors, such as a patient with history of ectopic pregnancy and pelvic inflammatory diseases, which may be caused by sexual transmitted diseases such as gonorrhea and others, or IUD, intrauterine device. That intrauterine device prevents the embryo from implanting into the endometrium. That leads to ectopic pregnancy. Okay, and IVF, in vitro fertilization, age, and endometriosis, which we have a separate lecture about endometriosis. So, and where is the most common area, that is the most common location that ectopic pregnancy occurs? It's in the oviduct or fallopian tube. Okay, so it occurs here. It occurs in the oviduct here. So when there's, for example, a intrauterine device that prevents the embryo, or that prevents implantation, so the blastocyst will implant in the fallopian tube. That's the idea of ectopic pregnancy. So now, as we said, the risk factors and the idea of ectopic pregnancy. Now we will talk about the presentation of ectopic pregnancy. It usually presents from 4 to 6 weeks after last period, okay, last menstrual flow, and it has the same symptoms of pregnancy, beside morning sickness and breast tenderness, just like a normal pregnancy, and vaginal bleeding. But when it reaches and you may have abdominal pain too, but if left untreated and or misdiagnosed, that ectopic pregnancy will rupture. Why will it rupture? Because the oviduct is narrow. It doesn't have the ability to expand like the uterus. So the fetus grows, the embryo grows and grows. That leads to rupture because the oviduct is narrow and can't resist that pressure inside. Okay. So, and we have, of course, we have elevated beta HCG just like pregnancy. Okay. And on ultrasound, you would see no evidence of intrauterine gestation. So, what's the management? The management is methotrexate and RHO-GAM and surgery. So, the most common management method or treatment is methotrexate, which is contraindicated in breastfeeding. So, what is the mechanism of methotrexate? So, methotrexate is a folate antagonist which inhibits dehydrofolate reductase. That dehydrofolate reductase enzyme converts dehydrofolate to tetrahydrofolate, and that tetrahydrofolate is needed for, it has thymidylate and purines such as adenine and guanine that are important for DNA and RNA synthesis. So as it is a folate antagonist, that makes the embryo, that prevents the embryo from growing more and more, that prevents it from rupturing. Okay, so this mechanism of dehydrofolate reductase simply, which is a folate antagonist, which this prevents the embryo from growing further and causing damage. However, methotrexate is used in other diseases such as cancers or molar pregnancy. Okay, it may limit the growth of cancer cells too. Okay, so the dose of methotrexate is 50 milligrams per meter squares surface area of the body. One dose is given, a single dose is given after 4 days of injection, methotrexate injection, single dose, the dose that I mentioned now. The beta HCG will be monitored. If the beta HCG dropped 15% or more, there is no need for repeating the dose. But if the beta HCG dropped less than 15%, second dose is given, and again the beta HCG would be monitored. So, and surgery, of course, if rupture occurs, emergency surgery is the best. So what are the signs of rupture? They have the signs of, it has the signs of shock, shock. And before rupturing, the patient will have lower quadrant pain. It's a unilateral lower quadrant pain, almost never bilateral. Okay, ectopic pregnancy will be never ever bilateral. It's always unilateral. So we have some differentials here. We have, what are the differential diagnoses? We have appendicitis, which is one of the differentials, but appendicitis does not cause HCG elevation. Okay? Does not cause, and appendicitis has fever and rebound tenderness. Okay? But it may look like ectopic pregnancy. So if a woman comes to you complaining from a severe lower quadrant pain, you should ask about the menstruation and do a serum beta HCG test to rule out ectopic pregnancy. The second differential is ovarian cyst rupture. In ovarian cyst rupture, just like ectopic pregnancy. If ectopic pregnancy ruptures on ultrasound, you may see free fluid in the pelvic region. Okay, uh, the same as ovarian cysts. But again, ovarian cysts will not cause elevated beta HCG. Okay, and molar pregnancy is another differential. Molar pregnancy, however, it has a grape cluster or a snowstorm appearance on ultrasound, but it has one thing that is similar to ectopic pregnancy, which is elevated beta HCG. So you should be careful on diagnosing. So when you do an ultrasound, you will be able to detect the difference between molar pregnancy, either it's complete or partial, and you will be able to differentiate between ectopic pregnancy and molar pregnancy. So a quick review. Ectopic pregnancy is known as the extrauterine pregnancy. Where's the area that, with the location that most commonly occurs? It's in the fallopian tube. Okay, sometimes in the cervix. What are the risk factors? Patients with pelvic inflammatory diseases, PID, IUD, IVF, and endometriosis. Okay, presentation, as we spoke about, has the same pregnancy symptoms and vaginal bleeding, abdominal pain. When it ruptures, it causes acute abdominal pain and severe abdominal pain. And the management was methotrexate, and we explained the methotrexate, which is an antagonist for folate. The differentials were appendicitis, ovarian cyst, rupture, molar pregnancy, spontaneous abortion. Don't forget that information. If your beta HCG 2000 is 2000, you should be able to see a pregnancy, intrauterine pregnancy, through transvaginal ultrasound. But if your beta HCG is 6000, you should be able to see it through abdominal ultrasound. So thank you.